Well, Dr. Das in the United Kingdom has also got an interesting talk because we've just been discussing the possibility of changing, influencing the rate of growth of small aneurysms with a drug. So, Dr. Das, can you please give us your presentation?
Okay. Thank you, Mr. Chairman, and the organizing committee for this invitation. Oh, this is my declaration in that I'm an investigator for the clinical trial using phosphodiesterase inhibitor to control the growth of abdominal aortic aneurysm, and this study has been sponsored by Koya. Recently, a predictive modeling study was quoted that there may be more than 1 million people in the United States today living with abdominal aortic aneurysm. This raises the question of manpower and resources to deal with this extra demand. So despite the success of open and endovascular surgery in the management of abdominal aortic aneurysm, there will remain the quest for finding compound to prevent development, progression, and rupture of abdominal aortic aneurysm. In order to find new drugs to control abdominal aortic aneurysm, we must understand the pathogenesis of abdominal aortic aneurysm development. It is well known that there are important differences between atherosclerosis and aneurysms, as has been illustrated in this very special slides. We also know that various demographic factors and genetic predisposition contribute to the development of abdominal aortic aneurysm. There are, however, many pathological processes that trigger the development of abdominal aortic aneurysm as follows. Chronic inflammation, which is the hallmark of the aneurysm development. Degeneration and apoptosis of vascular smooth muscle cells. Proteolysis and degeneration of the extracellular matrix due to matrix metalloproteinases. Oxidative stress or generation of reactive oxygen species. Endothelial cell alteration. Dysfunctional endoplasmic reticulum and mitochondria that results in development of various protease enzymes. And formation of intraluminal thrombus itself has got some role to play. And finally, the lack of fibrin 4, which is known to be responsible for the development of elastin and collagen to the aortic wall. Drug development over the years have been targeted towards above-mentioned pathological changes. There have been several promising animal experiments using various kinds of drugs with properties of anti-inflammatory effect using like macrolides, non-steroidal anti-inflammatory drugs, statins, ACE inhibitors, JN kinase inhibitors, and interestingly, NFK beta ETC transcriptor protein decoy strategy, which has got a great anti-inflammatory effect as well as inhibition of various matrix beta metalloproteinases, as well as it helps in the synthesis of extracellular matrix. The second mode of action is inhibition of proteases. In addition to the NFK beta ETC transcriptor decoy strategy, there are MMP inhibitors like MMP2, 9, 13, antibiotics like tetracycline, doxycyclines, commonly used medications like statins, and again, JN kinase inhibitors. Thirdly, the antioxidant effect, which reduces the reactive oxygen species. And the most common drugs are vitamins and statins. And finally, the synthesis of extracellular matrix using statins, JN kinase inhibitors, and again NFK, ETC, transcriptor factor decoy strategy. So there is a whole range of compounds that have been used in animal experimental with some success. However, a Cochrane review by Stansby et al. In 2014 concluded that currently there is no validated medical therapy through randomized clinical trials to prevent the progression of abdominal aortic aneurysm. That said, there have been some encouraging observations using very commonly used drugs like metformin. In a large study, retrospective cohort study of more than 14,000 diabetic patients with aortic aneurysm, metformin reduced the aneurysm growth rate by over 23%. In another study, where statin was used and it was a systemic review and meta-analysis involving over 80,000 patients, the mean AA growth rate was reduced. There was lower rupture risk. There were lower 30-day mortality after elective aortic aneurysm repair. The crude rupture rate and crude 30-day mortality rate were also reduced in the statin group. So in conclusion, this study also suggested that there is benefit like metformin with the use of statins in controlling the growth rate of aneurysms. However, the above-mentioned observed clinical benefits have not been confirmed by rigorous clinical trial. And that is the problem that we are facing today in trying to use these medications in our patients. We cannot justify regular use of these medications until we have good evidence that these medicines are safe on long-term use to reduce the growth rate of the aneurysms. So, following successful experimental study in mice, we are currently involved in a large international multicenter study using phosphodiesterase inhibitors to address this question. Cilostazol, which is a phosphodiesterase inhibitor, has been tried in our experimental study, and it showed that angiotensin II infusion increased maximal diameters of abdominal aorta, whereas cilostazol administration significantly attenuated dilatation of abdominal aorta, and thereby reducing the incidence of abdominal aortic aneurysm. Furthermore, cilostazol also reduced macrophage accumulation, matrix metalloproteinase activation, and inflammatory gene expression in the aortic media. So this is slide which shows in the group which was treated with angiotensin alone how the aneurysm formation continued, but when they were treated together with cilostazol, the growth was reduced completely, attenuated completely. And this is very significant from our trial perspective. So we are now currently involved in a study recruiting, and the aim is to recruit about 750 patients with small abdominal aortic aneurysm measuring between 4 to 4.5 centimeter in maximum diameter. The study duration is over 5 years. We will randomize 750 patients, 250 patients in each arm, and there will be 45 centers we expect in the United States, UK, and Europe. The dose of the phosphodiesterase inhibitor that will be used is 50 milligram twice daily. The second arm will be 100 milligram twice daily, and the third arm will receive placebo. We hope that our study will provide the answer that we have been searching over the years. Thank you.
Thank you very much indeed, Dr. Das.
Thank you.